Good afternoon. My name is Dr. Clement. Dr. Clement has come back again to say something about a good diagnosis by a healthcare worker. The healthcare worker says, right, this patient has got a seizure. We need to talk a little bit about a seizure for everybody's clarity. A seizure is an abnormal shall I say synchronization of the cortical neurons. The cortical neurons I'm talking about are neurons in the cerebral cortex. When they are working, they're supposed to work together. They're supposed to be in harmony with one another. They are not supposed to be working out of sync, so to say. Each one doing its own thing, this one doing its own thing. They're supposed to work together. And when they work together, that's a normal synchronization. That's very good. But when there's abnormal synchronization, in other words, they are out of sync, they are not working together, then something results, and that is a seizure. Seizure has got to be avoided at all costs. I've seen how embarrassing a seizure can be. Gentleman having his suit on, everybody praising him for looking smart, and now this abruptly happens, and then he messes himself, the urinary incontinence. Oh no. Right? He messes himself. He is unconscious of what is happening. But when the consciousness comes back, it becomes a problem now. He starts now feeling so embarrassed about the situation. So this can be avoided. Put the patient on treatment, and so that the seizures are well controlled. First of all, the care worker has done a good job. The care worker, or the health care worker, shall I say, the doctor, the nurse, they've done a very good job. They have decided to diagnose this problem and say, is this seizure from an epileptic cause, or is this seizure from a non-epileptic cause? I'll give you an example of a non-epileptic cause. Hyponatremia, for instance, and an electrolyte abnormality. You can get a seizure from hypocalcemia, for instance. You can get a seizure from, like I say, hyponatremia. You can get a seizure from a hypoglycemia. Maybe I should say, what happens during a seizure? There's rapid flow of blood. Rapid flow of blood. That gives rise to hypertension. That gives rise to a high blood pressure because of the fluid, the blood that flows in so rapidly. And there's also a rapid utilization of glucose. This rapid utilization of glucose gives rise to a generation of lactic acid. Lactic acid gives rise now to metabolic acidosis. So this patient, this is what this patient is having now. This is what this patient is having, metabolic acidosis. So once there's metabolic acidosis, you look at the pH is low. There's a drop of pH. So this is what is happening with this patient. Rapid utilization of glucose. And this is understandable when you say then there will be a generation. You know, there's this aerobic and anaerobic, shall I say, breakdown of glucose. During the anaerobic breakdown of glucose, there's generation of lactic acid. Right? So lactic acid will give rise to what? To give rise to metabolic acidosis. And metabolic acidosis is what? If you look at the pH, if a patient who's got that, the pH is low. This is what is happening. So the healthcare worker wants to address this problem. He says, am I going to say it's epileptic? All the healthcare worker sees is a seizure. But now he or she needs to classify this as epileptic or non-epileptic. Like the example of given, that of hyponatremia, that's non-epileptic. But it causes a seizure. When the patient is actually having the seizure, you can't make out whether this is non-epileptic or epileptic. No. Now, how do you get to know that it is epileptic? Well, epilepsy, those are repeated seizures. But you don't know, you're just meeting this patient for the first time and the patient is having a seizure. So you can't decide whether it's epileptic. What is... Okay. The healthcare worker has to get to know that there's a gland known as the hypothalamus, and this is activated by a generalized tonic, clonic tonic seizure, or a complex partial seizure. So the type of a seizure is important. There can be an absent seizure, that one doesn't cause that. There can be clonus seizure. There can be a tonic seizure, but there can be a generalized tonic clonic seizure. That one, it activates, and the complex partial seizure, it activates the hypothalamus, and the hypothalamus controls the pituitary gland, or the hypophysis. Hypophysis is divided into two. It is having an area known as the adenohypophysis and the neurohypophysis. The adenohypophysis is the one that releases prolactin. It releases quite a number host of hormones. But now one of them is prolactin. So prolactin is activated by the generalized tonic clonic seizure, and it will be released. And this serves to differentiate between a non-epileptic seizure and an epileptic seizure. Once you see prolactin, then you know then I can think about clonic or a clonic tonic seizure. And this is which is epilepsy, which is epileptic. So that classification helps you to manage the patient. And if it's non-epileptic, well, you get the results from the lab and they say, oh, there's low levels of sodium. So you say, oh, this is hyponatremia. This was non-epileptic, it was caused by... But now, maybe I should finish up with generalized tonic-clonic seizure, when it activates the hypothalamus to release what? To release prolactin. So prolactin is an indicator hormone now to say that, oh no, this is epilepsy. We will talk about this. But you can also get this prolactin with syncope. You know syncope? Fainting. It also produces that. But of course, you'll be able to differentiate if you're actually here and you saw the patient fitting. I mean, there's a difference between fitting and fainting. You know, in other words, syncope and an epileptic fit. You'll be able to differentiate. And of course, even from the collaterals, you'll find out from history that this was a fit and this was just a normal syncope. Well, from the history, you'll be able to make out as a healthcare worker. The problem, you know, the healthcare worker has done very well so far. But now, if it is hyponatremia, it's non-epileptic and it's hyponatremia, and you want to address this problem, you say, oh, it's because there's a shortage of sodium. So I've got to add sodium. The how part of it is very important here, because if the how part of it is not addressed appropriately, in other words, there's a rapid replacement of sodium. Whoa. We're generating what is known as pontine myelinosis. Oh, a very devastating condition where the myelin sheath is actually removed. I mean, you think of this of the sodium of the cerebrum as it is. That myelin sheath being removed. You think of the spinal cord, the myelin sheath being removed, corticospinal, corticobulbar myelinosis. Oh no, this is the worst thing that can happen. And this is avoidable by slow replacement of sodium. So slow replacement of sodium. And this is all caused by osmotic shifts. You know, you have a lot of solute. In other words, you replace it sharply, so fast. And then there's a lot of sodium now. So there's going to be a motion of water from a region of high concentration to a region of low concentration. Obviously, where there's a lot of solute, a lot of sodium, that's a region of low concentration of water. So water is going to move from a region of high concentration to a region of low concentration. That's osmosis. That is osmosis. And if that happens, there can be the problem that you have is that of pontine myelinosis. Pontine myelinosis. There can be a a locked-in syndrome because of this. If you say, I'm going to address the problem of abundance of water, because if there's very little solid, it's hyponatremia, there's very little sodium, low levels of sodium, but abundance of water. Your attack can be, let me remove the water. So dehydration or rapid dehydration, so in both cases, it's rapid, it's a replacement of sodium. That is incorrect, very inappropriate. That causes the pontine myelinosis. And there's now a rapid dehydration that you decide, look, let me remove the water. Rapid dehydration is going to give rise to a hyperviscosity syndrome. The first one gives rise to a locked-in syndrome, where there was solute, a lot of sodium being given rapidly, so a locked-in syndrome. Both of them, they are very destructive to the patient. So you can't afford to have a locked-in syndrome. You can't afford to have a hyperviscosity syndrome. All these, they give rise, they remove the myelin sheath. They remove the myelin sheath. And the removal of myelin sheath, you can think of the brain which does not have any myelin sheath. You can think of you can think of the spinal cord which does not have the myelin sheath. This is corticobulbar. All those don't have myelin sheath. This is a good diagnosis, but addressed inappropriately. It's a good diagnosis on the part of the healthcare worker. The doctor has done very well in diagnosing this. Says, no, this is hyponatremia. Hyponatremia, it means there's very little sodium, so I must replace the sodium. But the how part of it, how do you replace it, is very important. It must be replaced very slowly. Very slowly. Very slowly. In other words, no rapid replacement of sodium, because it will give rise to this pontine myelinosis, which is the most dreadful condition that you can think of. Patients, they go into a coma, they die. They go into a coma, they die. This is what I would like people to take home today. Think of pontine myelinosis as being caused by an address of a problem inappropriately. This is a problem that you diagnosed so well. You said, this seizure is caused by hyponatremia. Hyponatremia being an electrolyte abnormality. And you addressed it, you said, I'm going to make sure that this water goes away. Because that's what is responsible for making hyponatremia. Because there's an abundance of water, there's very little. And then you do rapid dehydration, which is the worst thing that you can do. Rapid dehydration is going to give rise to a hyperviscosity syndrome. And rapid replacement of sodium. So both of them must not be rapid. Rapid replacement of sodium is going to give rise to pontine myelinosis. And this is the worst. It's going to give rise to a locked-in syndrome. Locked-in. Patient looks locked-in syndrome, gets a locked-in syndrome. This is something that has got to be remembered so very well when managing these patients. In fact, it's always a good idea when a junior healthcare worker gets this as a diagnosis. If you take it to your seniors, you take it to the medicine department, they know exactly what to do with those guys. They do that only, like that's their work. They enjoy doing it. Take it to them, report it. These are my findings. I find that my patient had a seizure, and I did some investigations. I noticed that it's caused by hyponatremia. Take it to them. Take it to them. Don't take chances and start managing the patient in a way that you are not sure of. It's always a good idea to take it to senior people who can manage this patient very, very well. And of course, you will be praised for getting a correct diagnosis, to know that this is non-epileptic. In other words, you didn't find any prolactin. Hey, that would be very good if you report that to your senior doctor, that you didn't get any prolactin. You're going to be praised for the fact that you know that when you want to say it is epileptic, then I must look for prolactin, because I know that there's activation of hypothalamus by a generalized tonic clonic seizure, or a partial or a complex partial seizure. They will activate the hypothalamus, and the hypothalamus will in turn activate the hypophysis. The hypophysis, knowing that the adenohypophysis is the one that will release prolactin. This will be activated to release prolactin. And this is something, if you know this, you'll be well respected by your senior doctors, because your senior doctors will take anything that comes from you, because you go deep and find out what is the cause of this seizure, and of course you address the seizure, stop the seizure, and people know very well in a casualty setup. They know how to do it. Thank you very much for listening to me, and I hope I'll be wrapping up some of these, these, making sure that everybody understands, making sure that I don't take for granted that people know what a seizure is. I remember yesterday I was giving a talk about, onset of a seizure being caused by what, and this is, I was talking about, but I assumed that people know what a seizure is, and that's not right. On my part, I think I have to correct myself. No, let's make sure that we know that it is abnormal synchronization of the cortical neurons in the cortex. It is that's what a seizure is, and there's no working together between these neurons. Thank you very much. Thank you very much.